Welcome to week 2 of our course in economic evaluation in global health. Last week we started out by describing global health and the different kinds of health interventions that we can use to improve health outcomes. We then also set out the rationale for performing economic evaluations and deciding whether one intervention is more cost effective relative to another. So this week we'll look at the different methods used to perform economic evaluations. The goals this week are firstly to understand the different methods of economic evaluation in healthcare, but importantly to understand the differences between the methods. And we hope that at the end of the week people will be able to identify when a method of economic evaluation has been deployed in the literature. When you read a paper, are you able to identify which method was used? And finally, if you're interested in actually doing an economic evaluation, to be able to make the choice of method to deploy given the question that you have. Week 2 is divided into 3 parts. In the first part, we'll introduce the different kinds of economic evaluation and speak in detail about cost consequences analysis and cost minimization analysis. We'll then shift in a second part to cost effectiveness and cost utility analysis, and we'll finish the week by discussing the method of cost benefit analysis. So let's jump into part 1, and this week we are going to use a recurring example of an analyst who's working in the country of Malawi. So essentially on the cost side, he would be assessing costs in Malawi kwachas, and we'll keep using this example as we go along this week. So let's look at healthcare evaluation in general. We can ask ourselves 2 questions, and up here we have the question of whether we are assessing both costs and outcomes of alternatives, and down here we have the question of whether we are comparing 2 or more alternatives. And if we are not comparing both costs and outcomes, then we have partial evaluations. And if we are not comparing 2 or more alternatives, we have partial evaluations on the outcomes side, which are outcomes description here. And then we have cost of illness studies, which compare costs only of interventions of only one intervention, essentially one disease area, and this is cost of illness right here. And in later weeks we'll look at cost of illness studies. And if we are comparing only costs or only outcomes, but of 2 or more alternatives, then we have traditional epi studies here, like a randomized controlled trial. And if the comparison is on the cost side, but of 2 or more alternatives, then we have a cost analysis here. Now, if you compare both costs and outcomes, but you are not comparing 2 or more alternatives, then you have a cost outcome description, which is right here. However, this week we're going to focus on what we call the full economic evaluations, which mean that you are comparing both costs and outcomes of alternatives, and the comparison involves 2 or more alternatives. And these are the 5 methods which are in this bottom right hand corner. And in this slide we have the 5 different types of full economic evaluations, and in the left hand column we have the method, in the middle column we have cost measurements, and in the final column we have the description of the outcome. And the description of the outcome right here is what sets the methods apart. The cost side is uniform across methods. You need to measure costs in some currency. Now in our example we said that we're going to be using Malawi kwachas, so you can say that you have Malawi kwachas here in all these boxes instead of US dollars. But the idea is that you have monetary units in the numerator of the cost effectiveness ratio for all the different methods. What makes them different is the measurement of outcomes. In cost consequences, you have a multi-dimensional listing of outcomes, and we'll see exactly what that looks like. in cost minimization, you have equivalence demonstrated or assumed of the outcomes in the method, and you are interested in which method is essentially cheapest. In cost effectiveness, you have some natural units, and usually these are clinical units. In cost utility analysis, you have a combination of quality of life and life expectancy, and the two common ones are QALYs and DALYs, and we'll look at how to estimate those in later weeks. And then in cost benefit analysis, you have dollars on both sides. The outcome is monetized, so you would also have Malawi Kwachas here. Let's look at the application of economic evaluation methods for achieving different analytic objectives. So if you wanted to achieve a specific objective, you can choose between all 5 methods. However, if you wanted to assess options across the health sector, then you only have 2 methods to choose from, and that's cost utility analysis and cost benefit analysis. And the reason you can use cost utility analysis is because it combines length of life and quality of life. So you can compare interventions that prevent mortality and interventions that are mainly designed to prevent morbidity. You can compare helmets to prevent accidents for motorcycle riders with antidepressants, which manage a condition that doesn't have immediate mortality consequences but can substantially affect quality of life. Now, if you wanted to expand that and assess interventions in the health sector and outside of the health sector, for example in the environmental sector, then you only have cost benefit analysis to use. And the reason is that if you have money on both the denominator and the numerator, then you can calculate what they call a benefit to cost ratio. If it's greater than 1, that is the benefit to cost ratio is greater than 1, that's a good intervention essentially, and it should be pursued. And that's called in general terms the assessment of intrinsic value, that something has benefits that exceed the cost, and therefore it's a good intervention. Now we're going to move on to the different methods one by one, and as we do this, we are going to give examples. Let's start with cost consequences analysis. Cost consequences analysis is a systematic description and measurement of different intervention attributes that you can use to make a decision. It does not prescribe a decision rule, and it mirrors everyday decision making because it provides information to decision makers in a simple and disaggregated format. It has a table that says here's the costs of intervention A, and here's the benefits of intervention A, and here's the costs of intervention B and the benefits of intervention B. So it allows decision makers to weigh the evidence on their own and make a decision. So it mirrors everyday decision making, like trying to choose between buying an iPhone or buying a Samsung Galaxy essentially. You can look at different attributes, color, weight, and then make your decision. The disadvantage is that it puts the onus on the decision maker, and this might maximize the welfare of the decision maker, but the decision maker might make a decision that is not in the best interest of the individual or the individual patient or even of the society. And here's an example of a cost consequence analysis, a prospective cost consequence analysis of adding lamivudine to zidovudine for treatment of HIV infection in the US. This paper was published back in 1999. And in this paper, the background was that this CESAR trial had been conducted in multiple countries, and it had compared the addition of lamivudine and zidovudine to zidovudine alone in the treatment of HIV infection. This was back when the options for treatment of HIV weren't as numerous as they are today. So at the time, it showed that the combination of lamivudine and zidovudine reduced disease progression and had a significant survival benefit. And so Lacey et al. Performed this study based on the results of CSER. They examined resource utilization in terms of hospital days, outpatient visits, and medications, and also the costs of HIV-related illness and adverse events. And they also examined the consequences of HIV with regard to disease progression and new or recurrent HIV-related illnesses. And here's the table from the paper which we recreated, but you'll see that you have two columns for placebo, which was zidovudine, and then you have the lamivudine plus zidovudine arm, which is labeled lamivudine here, and you have costs multiplied by $100, and this is for 100 patients over the trial period. So you'll see that it gives the different costs, the impact on progression and resource use, but doesn't try to give any sort of ratio. So a policymaker can decide which of the attributes is important to them. So if we take disease progression, for example, we see that in placebo, 20 over 100 patients progressed during the trial, but in lamivudine, only 9 progressed. So the difference was a reduction in the number of patients who progressed by 11. And if we look at the costs, then we will see that for medication costs, for example, the placebo was $56,000 and the lamivudine arm was $52,000, and that there was a reduction of $3,900 between the two arms. But the main increase in costs came about because lamivudine, then a new drug, was more expensive. So you'll see here lamivudine costs increased by nearly $300,000. So the point really is that in cost consequences, you have a table that gives you the costs of both interventions and the different consequences of both interventions. And as a decision maker, you can decide which intervention is attractive from your perspective. So having done this cost consequence analysis, the conclusion of Lacey et al., and this is a direct quote, was that our findings indicate that treatments which slow the progression of HIV infection have the potential to reduce the monthly costs associated with HIV-related illness and adverse events during the time period that progression is slowed. So they didn't try to say that intervention A was more cost effective than intervention B. That conclusion is left to the decision makers to make. So let's move on to cost minimization analysis. And in cost minimization analysis, you have to assume or to prove that outcomes are equal. And the purpose of the analysis is to identify the least costly option or the cheapest option. And historically, it was recommended for evaluations of trials that showed no statistical significant difference between the effectiveness of two interventions. But it's only technically valid if you have what are called non-inferiority trials. For those of you who have studied EPI, you know that these trials require large sample sizes, so they are specially designed to prove non-inferiority. The advantage is that they are simple to interpret, and you only have to prove that one intervention is cheaper than the other, and that's a good intervention because the outcomes are equal. The disadvantage is that a switch in perspective may alter the equivalence of outcomes, and then you no longer have equivalence of outcomes, and your analysis is not valid. And many people don't consider this to be a method of evaluation anymore, although I have found it useful, as we'll see in the next few slides. But there was a famous paper written by Andy Briggs and Barney O'Brien called The Death of Cost Minimization Analysis, in which they argued that even when you have equivalence of outcomes, you should examine the joint distribution of both costs and outcomes. And therefore, doing cost minimization studies wasn't a good idea at all. Here's an example of a cost minimization analysis in a paper that my colleagues and I did a few years ago, back in 2009, and it was on task shifting, which means the performance of clinical tasks by individuals who are of less sophisticated training, essentially like giving nurses the duties of prescribing antiretroviral medications. And in this study, it was in the setting of severe health worker shortages. As you know, in low and middle income countries, there are health worker shortages. And at the time, the Infectious Diseases Institute, which is in Kampala, in Uganda, had begun to task shift to reduce the workforce load on physicians. Their physicians were overloaded. And the aim of this study was assuming that using different cadres of health workers did not lead to adverse consequences for patients, how much money would one save and how many physician full-time equivalents, that's FTEs, would one save by shifting ARV duties from physicians to other cadres of health workers. So to do this study, we built an aggregate cost minimization model. We used two perspectives. We have the societal perspective and the governmental perspective. And we shall look at the differences in perspective in the week in which we shall study costs. But briefly, the societal perspective includes all kinds of costs, and the governmental perspective includes costs that the government would incur if it runs the Ministry of Health, for example. And we had three arms in the study. We had physician follow-up, nurse follow-up, and pharmacy worker follow-up. And as we saw, a full economic evaluation is one in which you have multiple options being compared, both in terms of their costs and consequences. So this is a full economic evaluation. And the key assumption was that there was no difference in health outcomes. And we used data from the IDI clinic with regard to resource utilization and unit costs and wages, and valuing lost time based on Uganda's GDP per capita. And we also did national projections and sensitivity analysis. And these are the results. So we did a time motion survey, and we'll look a little bit in more detail about time motion surveys. But we wanted to examine waiting time and physician and other cadre personnel use time. So you'll see that people wait a long time to see patients than to see maybe a triage nurse or a regular nurse. And this is the driver of resource use. And next week we'll see how resource cost equals resource use times unit cost. But here the key resource use was physician time. And if you move on here, you'll see the per visit cost. So essentially, once you take time into consideration and you multiply that by the wage of the different cadres, you see that physicians are the most expensive. And for every visit, a physician, the total per visit cost per patient, essentially at the end, in the last column, is $2.50 for physicians and $1.7 for nurses, and $1 for the regular nurse, and then for pharmacy workers it's 80 cents and 22 cents. So physicians, as expected, were the most expensive. And here's the main results table. So on an annual basis, the per visit costs for different cadres, you see in this last part here, see that the total cost for using the physician follow-up would be about $32. For nurses it would be $27, and for pharmacy workers it would be $10. And if you used the societal perspective, it would go up to about $60 for physicians and $45 for nurses and under $20 for pharmacy workers. So if you do this on a national level, then if you have on this scale in millions of dollars, on this scale, then you'll see that using nurses and pharmacy workers saves the country a little bit of money. And the different bars are by different perspectives. The dark bars are societal perspective, and the light bars are payer perspective, and the payer in Uganda is the Ministry of Health. And so we demonstrated that assuming equivalent outcomes, it would be best for patients to receive their medications in the pharmacy instead of having doctors and nurses see them on a month-to-month basis. And when we did the full-time equivalent analysis, we saw that task shifting to nurses and pharmacy workers based on different levels of access to ARVs would save between 100 and 330 physician full-time equivalents, which would be between 5 and 15% of the national physician workforce. So it would really save physician time, and presumably you could use this physician time to do other clinical work. So maybe these physicians would go and do surgery, would do cesarean sections instead of seeing HIV patients on a month-to-month basis. And the conclusion was that task shifting would save between $500,000 and $11 million annually, depending on the perspective and the level of access to ARVs, and that there would also be substantial physician FTEs saved. So we come to the end of part 1 of week 2, in which we looked at cost minimization analysis and cost consequences analysis. And cost minimization means that outcomes are equivalent and you want the cheapest intervention. And cost consequences means that you have a table and you list the costs and different consequences, and decision makers have to decide which attribute of the interventions they are interested in and use that as the basis for their decision. In the second part, we're going to look at cost effectiveness analysis and cost utility analysis. Thank you very much.